Great, and welcome everyone to the AIHM Friday Wellness webinar. I'm just letting everyone come into the Zoom. Thanks for coming to this week's presentation. We're really excited to have Dr. Datis Kharrazian with us from the Kharrazian Institute, and we are going to be doing a conference with him for our members. So we're really excited to have him and have a chance to talk to him a little bit about his work. So for those of you who are here for the first time, the Academy of Integrative Health and Medicine, AIHM, is a global interprofessional integrative health association working to transform healthcare, body, mind, spirit, community, and planet. And we have been around since 1978, originally as the American Holistic Medical Association, and now as the Academy of Integrative Health and Medicine. So I really want to welcome our special guest today. Dr. Datis Kharrazian has his PhD, he is a chiropractor and has just studied in so many areas, has been a leader and pioneer in the integrative and functional medicine worlds. He is a Harvard Medical School trained researcher, a clinical research scientist, academic professor, and a functional medicine healthcare provider. He develops evidence-based models to treat autoimmune, neurological, and unidentified chronic diseases with non-pharmaceutical applications. And he has won several awards, including the Researcher of the Year Award by the International Association of Functional Neurology and the Clinical Trailblazer Award by the International Association of Functional Neurology and Rehabilitation. For those of you who have studied with Dr. Kharrazian or seen him speak at one of the AIHM conferences, he is truly just one of the most brilliant teachers we have in this space. And so I just really want to welcome you today, Datis, and thank you so much for being here with us.
Thank you, Tabitha. It's really great to be involved. So should I just go into my topic and just start speaking?
Or? Yeah. Well, so I think you were going to talk a little bit just about, clinical mistakes in approaching GI challenges. And certainly we welcome just questions from the audience as we go through this chat with each other today.
Okay, great. So I just want to, for the topic, and this is, when you asked me like, hey, would you want to speak on the topic? Well, let's talk about this one because this is really important. As most of us that practice any kind of functional medicine, integrative medicine, preventive medicine, and we looking at diet, nutrition, lifestyle to really change your patient's chronic disease. The key thing, we always have to deal with is really looking at the gut. And, the simple models like always start with the gut seem to be incorrect. So, the gut, the gastrointestinal tract can be impacted by metabolic conditions. For example, if someone has uncontrolled diabetes and their HbA1c is high, you're not going to be able to fix leaky gut. You're not going to be able to change your microbiome. You can have very little effect with them. So some people have neurological diseases, neurodegenerative diseases where they're not getting vagal input. Some people have hyperperfusion issues where they're not getting enough blood flow to the gut. Some people have autonomic dystonias where they can't control the integrative pathways there. That are all involved with gut function. So, many times, and I think one of the things that's always said too often in the field of functional medicine is you always have to start with the gut, but a lot of times you can't fix the gut until you fix other things. So I wanted to kind of touch upon that as a general concept. And then, as a practitioner, as a clinician, I think for those that are starting to do more of a functional medicine model into their practice, they're sometimes frustrated because they get that weird patient where nothing works. They've tried everything and taken handfuls of supplements, and that's a red flag. And that actually helps you with your diagnostic mechanism of what may be going on. So let me start with that. Let me start with the patient that walks in and they come in, they got bags full of supplements in each hand. They put their supplements down, earthquake shatters because they're taking so many things. And you start pulling them out one by one and going, how can you possibly be taking these things? Or you see a patient come in and they ask for the list of supplements, maybe it's in your intake forms, and they give you a piece of paper because it was so many, you didn't even fill your forms. And then you look at it and go, oh my God, you're on so many things. And you flip it over and there's even more. Those are chronic patients. The chronic patient that's just desperate, trying to figure out what to do, is trying one thing after the another. And a lot of these, a lot of these patients aren't doing it on their own. They're seeing practitioners, and the practitioners are desperate, and they're just prescribing one thing after the next, after the next, after the next, hoping that something will actually work. So, one of the first things I think is really important to understand about the GI tract, there are some conditions that are not going to respond to anything you do with a diet, nutrition, lifestyle issue. Not to say you shouldn't do things for them, but you need to know what you're dealing with. So I think one of the reasons practitioners get really frustrated especially those that are new in functional medicine, is that they just don't understand that not every single gastrointestinal or chronic condition is completely curable or treatable there in a way where you're going to immediately see the same outcomes as other people. So let's talk about the red flag patient. The red flag patient is the one most of you have probably all seen in your practice. They come in, they're taking countless amounts of supplements. They have chronic gastrointestinal issues. They always complain about chronic symptoms, and have a stack full of labs. They've seen all these people, lots of things that are wrong. And despite those mechanisms, they still have symptoms. And nothing's really helped them. They're really confused. Some things have helped here and there, but nothing really makes sense. So that's your classical autoimmune disease patient. And for these patients that have autoimmunity, some of them have intestinal autoimmunity, some of them have, the obvious one, celiac disease, but some have Crohn's, some have ulcerative colitis, some have just some intestinal autoantibodies that hasn't progressed to disease yet. But whenever you see a patient that comes in, they're taking all these supplements, and then you look at their diet, and their diet's really healthy. So you're seeing like a perfect diet, you're seeing lots of good supplements, you're seeing like, wow, you're doing everything right. You're eating really well. You're off all these inflammatory foods. Let's say they come in, they're already gluten-free, dairy-free, soy-free, egg-free, or they're an autoimmune paleo diet. They're taking tons of supplements, and they still have a lot of gastrointestinal symptoms. So that's your first clue that they may really have intestinal autoimmunity, right? So lots of people actually have intestinal autoimmunity that hasn't progressed to the point where they're going to have endoscopic evaluation of Crohn's disease or ulcerative colitis, or have significant amount of symptoms. So there's a level between where someone has subtle autoimmune disease expressions, which they call autoimmune reactivity, until they develop full-blown autoimmune disease. So there are a lot of people that have chronic gastrointestinal issues that really have autoimmune reactivity. And the only way you can really find them is to measure antibodies for their gut. So things like transglutaminase 2 to look for a celiac underlying pattern could be an important thing. Looking at ASCA or ANCA antibodies can be very important. Tropomyosin antibodies. So there are a lot of people that have these chronic issues that really have intestinal autoimmune reactions that get totally overworked in the healthcare system. So I think one of the reasons why people, a lot of practitioners that I've seen and have worked with, and most of us, we see files of other patients that are coming in that are really having a hard time with some gastrointestinal issues or overworking, is that they miss that these patients may have some intestinal autoimmunity. So that's one group. And if that's the case, your prognosis has to immediately change and go, listen, you have intestinal autoimmunity. We really need to understand that autoimmunity, it's not really about cure. It's about trying to get you in remission and keeping you there as long as possible, but you're still going to have relapses. And once you can identify the mechanism, if it's being, for example, in this scenario, autoimmune, and you have a realistic prognosis, you can see the weight of the patient just relax. They know what's going on. Things start to make sense. They now understand that this thing isn't a big mystery thing. And a lot of these patients that have autoimmunity, by the time they go to different healthcare practitioners, they're almost nervous telling their history because they think they're crazy. No one believes them. So these people that are stuck in the autoimmune reactivity stage, before they have full expression, destruction of their gut, are one of the areas that really, I think, is overlooked in the healthcare system, including functional medicine. So that's one thing. Another major group of people that are really that really struggle with chronic gastrointestinal dysfunctions that are typically overlooked and missed in the healthcare model, are patients that have early neurodegenerative diseases. And one of the best examples is patients that have early Parkinson's disease. So when you look at Parkinson's disease is a neurodegenerative alpha-synucleinopathy that starts in the enteric nervous system. And then it takes sometimes 10, 20 years before the disease progresses to areas of the basic ganglia where they start to have tremor. So tremor is actually one of the last expressions of Parkinson's disease. The earliest expression of Parkinson's disease is actually constipation that is there all the time, and loss of smell. And smell, the researchers have found with several studies that have been reproduced, they initially lose smell to anise, coffee, and peppermint. They're very strong. So those are things definitely want to test if you suspect Parkinson's when you do an olfactory assessment. But a lot of people that have Parkinsonian or early Parkinson's, what happens is the alpha-synucleinopathy, the protein aggregate disorder, ends up destroying the enteric nervous system first. So they don't have intestinal motility, they don't have intestinal contraction. Listen, and these are going to be the patients that walk into your office and say, I have to take a laxative every single day. Like I have to take magnesium every single day. If I don't do that, I can't have a regular bowel movement, or I have to do a coffee enema or something to help relieve bowel movements. That is an immediate red flag for a enteric nervous system disorder, which is really neurological based. And then one of the most common causes of that is really Parkinson's disease, or I should say Parkinsonism, because we don't know what type of Parkinson expression they have. If they have just typical Parkinsonism or supranuclear palsy or cortical basal degeneration, or whatever. But the point is that they have this alpha-synuclein aggregate disorder that's happening in the gut. Now, another key thing to understand with them is what the research is showing is that the alpha-synuclein protein aggregates get into the gut nervous system, and those protein aggregates decrease nerve transmission. And as they decrease nerve transmission, there's not enough neurological activity, and then the valves, the smooth muscles can't contract, so food just sits around the stomach. And when in undigested food or food that's in the small intestine, large intestine can't move, you get fermentation, you get dysbiosis, just from the lack of motility. So, if you ever did a GI panel in these patients, they're going to have everything wrong. They're going to have dysbiosis. They're going to have yeast overgrowth. They're going to have lack of enzyme issues. And you can treat all those things, but nothing will happen because the underlying mechanisms causing all those imbalances is that there's not enough neurological input to the gut because of this early neurodegenerative disease. Now, if it progresses, and the research shows that when they look at this enteric nervous system model, early Parkinsonian model, it starts in the enteric nervous system and then goes up the vagus nerve and starts to hit the vagal motor nuclei. And the next thing you'll see is they can't swallow. So they lose their ability to swallow. So then there'll be the patients that come in and say, please don't put me in a lot of supplements because I can't swallow very well. Can you give me a liquid? Could you give me a powder? So in summary, like if you see the patient that walks into your office and says, don't give me a lot of supplements, I hate taking capsules, and I need to take a magnesium every single night to have a bowel movement, you pretty much have to rule out early neurodegenerative disease. Okay. And the most common one being Parkinsonian. Those patients will not respond like typical patients. You can give them all the probiotics, enzyme, all the things you want. It's not going to necessarily fix their gut issue because you're still not dealing with the enteric nervous system damage. So that's another subgroup of patients. So we talked about two major subgroups of patients that all walk into the healthcare system that don't do well, despite they don't respond like other patients respond, right? So they get overlooked. So one is definitely the autoimmune patient that doesn't have full-blown autoimmune disease, so they don't have complete intestinal destruction or they can't see it, but you can find them with autoantibodies to the gut. The second one is your neurodegenerative disease, the Parkinsonian patient that's there. And then the third one that's very similar to that is going to be the person who had a traumatic brain injury, and the injury is now caught up with them. So lots of research has been published on the long-term effects of traumatic brain injury and post-traumatic encephalopathy, where people have injury to their brain. Maybe it was a car accident they got into, maybe it was an athletic event, they bumped their heads or something. And what the research is finding is that when there's injury to the brain, that these neuroglial cells get activated and they get primed, and then that inflammatory response continues, and then they start to recruit other cells. And the effects of chronic injury to the brain may really have long-lasting effects. And also, there's been several studies that have been published, at least animal studies, where they found within the first 30 minutes that once traumatic brain injury is induced, that they end up with intestinal permeability. They get leaky gut. So we know that traumatic brain injuries end up causing intestinal permeability. And then they did an animal study where they then activated the vagal motor nuclei in the brainstem with after traumatic brain injury in these animals, which I don't know how they got past animal ethic studies reviews, but they did. And then they found that if the vagus was activated, that there was no intestinal permeability developed after traumatic brain injury. It just shows you how powerful the brain's input is to the vagus and the vagus is to the gut. So when you look at the vagus activation on the gut, the brain to gut axis mechanism, vagal activity impacts the vagal motor nuclei, the nucleus ambiguus. These control blood flow to the gut, enzyme release in the gut, and intestinal motility. So the output to the vagus is directly related to the total integrative output of the cortex. So if you like the frontal lobe and temporal lobe and parietal lobe and occipital lobe, these other areas all have a degree of frequency of firing and activation, and they fire directly down to brainstem centers. And those brainstem centers, like the vagus, will then control the gut. So one of the other things you see is a person that comes in and they have basically chronic gut issues. They also may have difficulty swallowing, may or may not. But it really comes back also to motility. The biggest thing that they're struggling with is that they can't have regular bowel movements. And it's not related to a need for probiotics, not related to need for enzymes or any kind of GI supplement or a 5-hour program or 4-hour program and all that stuff. It's really related to the fact they're not getting that big limpet to their gut. So those patients you can identify very quickly as well. First of all, you might look for a past history of head trauma. And the other key thing with these people that have significant brain trauma is that once an area of the brain has a significant degree of injury, the cells called glial cells get primed and they stay in a hyperactive state from that point on. And then they're prone to inflammation. And one of the key characteristics of primed glial cells from traumatic brain injury in the area where the brain was injured is inflammation will really impact that area of the brain first. So for some people, they, for example, injure their cerebellum, which controls balance and stability and calibration movement. And maybe they hit the back of their head and they injure their cerebellum. They get an inflammatory response. Maybe they're sensitive to gluten. They eat gluten. Or maybe they have something flare up their immune system. It doesn't really matter what the trigger is. But once they get into a systemic inflammatory response, they may end up, maybe they eat milk and they are sensitive to it. They eat milk and all of a sudden they get vertigo and dizziness. That's not normal. That's a very clear indication that there's area of the brain that's close to the threshold. It's firing, and it's probably from past injury to the brain. And if it's vertigo, then that would be most likely cerebellum prime glial cells. That person probably will have some brain gut issues. You can have another person that as soon as they eat something inflammatory to get tinnitus. That means the injury was in the auditory cortex. Someone else gets inflammation, they can't focus, they can concentrate, massive depression. They could have had the frontal lobe injury. So a lot of times these people have chronic gut issues, and then they're coming into your office for those complaints. They're coming into the office because I have this gut issue, no one can figure out, I don't know what to do. As you do their history and their timeline, you see they also tell you these weird things that when they get inflamed happen. And when you look at the symptoms they have, like dizziness or vertigo or depression or tinnitus or auditory hallucinations or scotomas or whatever they may complain about, that those are actually brain-based. And then you go, okay, well, this person is having some in-proportional reactions to inflammation that are brain-based. They must have had a traumatic brain injury. And then you would suspect that their brain-gut axis is not working. Now, really quickly, as a clinician, you can have them open up their mouth, say, look at their palate, and you should see those palatine muscles move. Those palatine muscles should contract. And then you just may not see much contraction there, right? And their gag reflex may be off. You can listen to their bowel sounds. And, if you listen to bowel sounds all the time, you kind of know what normal is. And you just hear really weak bowel sounds. They have them, they're very weak, just like a weak muscle trying to contract. And then you would suspect in those patients that the reason they're not getting the GI fix is because they have this brain-gut axis disorder. And that's the reason why they're not going to respond to just taking a probiotic or other things. Now, it's not to say they shouldn't, because taking digestive enzymes, taking probiotics, and fixing the permeability is going to improve their physiology and their health. It's just, as a practitioner, you now start to realize, okay, there's some bigger things there. So to kind of start off, a discussion on this topic, I just really wanted to talk about the 3 most overlooked areas of chronic GI patients, meaning just as a clinician, we all have the same experience. There's certain patients that walk into our office and we look at them and go, you've seen a lot of talented people. What happened? Right? Or you've had a lot of great lab work. People have done a really great job with you. Your diet's perfect, taking a lot of great supplements. Why are you not getting? What else is there? So autoimmunity, early neurodegenerative diseases, and traumatic brain injuries are 3 of the most common causes why people have these gut issues that don't get better. So,
and Dr. Kharrazian,
yeah.
how, you've been doing this for a long time. How do you see that getting more prevalent in your practice? Do you see that these particular 3 kind of challenges are increasing in common, being more common, or any thoughts around that?
Yeah, absolutely. And first of all, we talk about autoimmunity. The statistics and the prevalence of autoimmunity is growing worldwide. Many world conferences have shown this, and that they're looking at the epidemiological data. And so that's on the rise. And the gut is a major target for a lot of autoimmunity. Rates of celiac disease have exploded for various reasons. And so that's number 1. Number 2, neurodegenerative diseases are on the rise. And we have an aging population that is really, if you look at the most of the patients you see, they're not usually 15-year-olds or 16-year-olds in a preventive medicine model, which would be ideal. We're really seeing people at 35 and older, and that's where you start to see earliest signs of neurodegenerative diseases. And Parkinson's disease, Alzheimer's disease, they're on the rise. And traumatic brain injury, I just think, has always been there. We just have never caught it, right? I mean, traumatic brain injury, I'm not sure if the rates are going up, but it's pretty common. And I think for a lot of us, we didn't really understand how important the research was. And, in the past, it was like, well, you got a brain injury. Are you better now? Yeah, I'm not dizzy anymore after a week. Well, then that's good. Now we know that there's long-lasting effects, especially with all the research being done with football players in the NFL and all these soldiers that had blast explosive surgeries in Iraq coming back, and they're being investigated and studied. There really has been explosive research of the effects of injury to the brain, and especially been a lot of research on the brain to gut axis. Everyone in functional medicine talks about the gut to brain, where if the gut's not working, you have depression and mood disorders and all that. But the brain to gut axis is one of these areas that tends to be overlooked. So I think if you can catch those three things, you're going to be able to make it. First of all, one of the key things is that any kind of healthcare practitioners, when you're working with a person, is to go and give them information about what's happening with them. Happening with them is just as important as the protocol or kind of treatment with them, because the area of not knowing what's going on, the part of being confused and just feeling weird, not understanding what's happening, it's very debilitating for a patient's psychology. It has a psychoneurological immune effect. They get nervous. They feel hopeless. So one of the key things is if you can identify those mechanisms and find them, and then explain those to the patients, there's a dramatic change in their outcomes overall in their health and their well-being. So that's one. So even though some of these things are like difficult, like how do you deal with the brain injury or how do you deal with autoimmunity, they're hard conditions to work with. But now you can, let's say, focus on their brain autoimmunity or their brain injury a little bit more. Maybe you can focus on these other things more. Like their autoimmunity, maybe they have to implement a total autoimmune diet and lifestyle, that it's not just about their gut, but all the other things that trigger their immune response as well. So that's one part of it. Now, so that was one thing I wanted to cover, was just the three most common subgroups of people that I've seen in my career walking into the office, taking a perfect nutritional protocol on a great diet and still have GI symptoms that tend to get overlooked. So autoimmunity, early neurodegenerative diseases, and traumatic brain injury. I didn't really talk about the Parkinsonian early issues, but the Parkinsonian, just so you know, is very common. It starts with chronic constipation, gut issues, and then they end up with all types of imbalances. They may get diagnosed with SIBO or enzyme deficiency and a whole list of stuff. Nothing really helps them because they just don't have that motility contraction. And then it progresses to slowness. So you just see that they're stiff and slow, and they usually start with one limb. So they get a frozen shoulder or a frozen hip. Then it goes to the same side, and it goes to the other side. One of the key things is you look at their speed, and they start to just go really slow. And usually one side will be really slow compared to the other. So they get some kind of hypokinetic effect. So hypokinesia and stiffness and rigidity, if you ever see that in combination with chronic gut issues, and especially that they have to take laxatives, is a sign that you may be dealing with early Parkinsonian disease. Okay. Now, another group I wanted to talk about was not these three groups that come in that are difficult, but let's say they don't have those issues. Let's say the average person, not so to these extreme mechanisms, but a person that just comes in has some maldigestion issues, or they have a leaky gut and they're just trying to get it better, and they have some reactions to foods. They're not the end of the world. Nothing's helped. They don't know how to fix that's going on.
To just hear your approach, right? And just kind of how you approach.
Right. So for those types of patients, there's a really important principle that I think it's important to understand, which is the GI tract has a clinical hierarchy, and there's a physiological step-by-step domino effect response. And it starts with chewing, and the term is north to south, right? So do they chew? Do they produce saliva? Do they swallow? Do they make hydrochloric acid? Do they make pancreatic enzyme? Do they make bile? Are their small intestine tight junctions working? Do they have proper electrolyte balance in their colon? And then from there, that's all related to just normal digestion, right? And then if you go to the next level, and then you have like immune stuff. Are the dendritic cells overreactive? Do the regulatory T cells dysfunctional? Do they have intestinal permeability? Have they lost their immune tolerance? And then if you go one step further than that, you have the microbiome. Is their microbiome diverse, right? So a big mistake is people just jump to the microbiome. Like if you just jump to the microbiome, trying to give them probiotic, you're guaranteed to fail. Because if they have, let's say, gallbladder issue or hypochlorhydria, and you don't address those, you haven't addressed the underlying physiological steps and mechanisms that change the pH of the gut, that change the environment of the gut for everything else to work. So that's really important. And also, so it's kind of works in digestive mechanisms, immune barriers, and then microbiome and its diversity. So we see is like a lot of people will do like a biome test or some microbiome test and see this imbalance there and try to put them on a cocktail of probiotics and not really go from that north to south model and immediately just go to the microbiome. That may not have much success and they have very little clinical outcomes. And, you know, at the end of the day, you know, all of us that work with patients, we only have so much time before they go, you suck, I need to leave. There's only so many supplements that we'll try. There's only so many dietary changes that we'll try. Like, so you have to be, you know, one of the key things I think is you have to be very effective, very efficient right away, especially, you know, cash practice and we're, you know, there's the sacrifice for the patient. It's very real for them or if they're very, you know, sick, they just need to get answers quickly. And it's really important to go through those steps. So when you look at this north to south model, I mean, you still have to like do an exam. Do they have saliva production? Saliva production can be impacted by brain-gut axis issues. Saliva production can be impacted by autoimmune diseases. Many autoimmune diseases have antibodies to the salivary glands. That could be a reason why they're just not having their issue. Another key issue in the clinical history of swallowing issue is saliva production. Is it takes them forever to finish a meal. If they're the last person ever at a table, it's not that they're just chewing more. It's just because if you don't have saliva, you have to chew much more to digest and break down your food. So some people have early scleroderma, some people have early lupus. They actually have autoantibodies against their salivary ducts. And I mean, if you look at their mouth, they have some saliva, but you'll see they also complain of dry mouths. You may not be able to get far with them because they already have mechanisms that are impacting their digestion that are pretty significant. And in those patients, you would actually give them like saliva solutions to help them digest their foods that have a little bit of amylase and things that are really important. So, you know, you start with that. And then hydrochloric acid, they have to be able to digest proteins. So people, you know, when you look at digestive enzymes, you have to digest protein, fats, and starches. So digesting people that can't digest protein well, whenever they eat something like high in protein, they feel like they have a brick in their stomach or they have really bad breath after protein meals. But the biggest thing is just feel like they can't digest their food, especially if it's high protein, and they may even have aversion to it. So those are signs that they may have hypochlorhydria or not of hydrochloric acid. And there's people that can't handle starches or fibers as their pancreatic enzyme deficiencies. And there's people who can't tolerate fats or just avoid all fats. And they get missed all the time because they stop eating fats. They don't eat fried foods. So they don't have, you know, they eat healthy foods. They don't have any of those issues. Or another big clue that they have a gallbladder issues, they burp up fish oils every time they eat them. That's a strong sign that they have a gallbladder issue. So an interesting thing about the gallbladder is when we look at this north to south model is there's been a lot of research that's been published the past few years that shows bile salts. Bile salts actually aren't there just to digest fats, but bile salts actually bind to FXR receptors in the gut and G-coupled proteins in the gut, and they modulate autonomic and metabolic function of the gut. So when you have people have like biliary stasis or thick bile, they may not be able to actually modulate their metabolic immune response in their gut because bile salts or immune signaling agents also, they're not just there to digest fats. So like, let's say if the patient has a gallbladder issue and they have biliary stasis and they tell you don't give me fish oils because I burn up all the time. Or, you know, you ask them, well, you know, I don't, you know, what happens if you eat fat? They go, I don't eat fat. And you go, well, what would happen if you had some greasy food? They say I'd be bloated and distended for days, or I would feel uncomfortable. Those are gallbladder patients. And the key thing is, if you can't release bile salts, you lose a major signaling agent of what's necessary for the gut microbiome to function. And it can cause downstream effects. So you may never be able to fix a dysbiosis until the gallbladder is releasing bile salts. So, you know, that's kind of like the north to south approach. So we always start with digestion, make sure digestion's intact, and then eventually going down into the gut and then looking at TED junctions. And then an area of explosion of research that they're totally overlooked in the functional medicine, integrated medicine community is really what's called oral tolerance. So oral tolerance is how reactive the gut immune system is. Everyone just focuses on leaky gut, but when someone has severe food sensitivities or food reactions, and it's based on imbalance in their gut, we know that there's mechanisms involving dendritic cells that can be overactive, that are unassociated with leaky gut. There can be regulatory T cell dysfunctions. We know that hepatic Kupffer cell upregulation can have an impact on those mechanisms as well. Total SIGA count has an impact on those. So those are all the different variables that then are involved. Now, none of those immune variables are going to be effective if the first north to south part isn't working, if they don't have proper digestion and saliva production and hydrochloric acid and pancreatic enzymes and hydrochloric acid to change the environment and pH of the gut, then the immune system, the gut starts to dysfunction and fail. So again, try to treat a leaky gut when there's a gallbladder problem is going to be inefficient, or trying to treat a leaky gut when there's hydrochloric acid issues is going to be inefficient. And then once you can deal with the immune tolerance issues, which is, we can go into that in more detail, but then you finally get to the gut microbiome. And this is where all the magic actually happens, right? So all the stuff we hear about the microbiome being linked to everything now, which is fantastic that all this research is coming out. But this microbiome key characteristic is they really haven't found any really good bacteria alone that changes everything, even though we do know there's some beneficial bacteria that has some effects. But there isn't like one species. Everyone doesn't eat lactobacillus. And what they have really concluded with this microbiome research is they have to use machine learning, because these bacteria species all kind of work together, and there's multiple vectors and multiple variables, and how one bacterial species works depends on another's population. And we're not going to ever be able to like a lab test and go, oh, you need this one. And we also know that a lot of research is showing the probiotic you take will really depend on your pre-existing microbiome condition and your level and balance there to which bacteria probiotics may work. The different probiotics may work at a different time. But what does the average practitioner do?
That's right.
They'll take one they liked and work for them, and they go, oh, this is my one I like. You should take this one too.
Well, there's actually a question that one of the audience members is asking that is around this topic. She asks, with idiopathic constipation, would you say lactobacillus treatment is better than a treatment with psyllium? Or do you have an approach? Like, how would you
say you waste your time? You waste your time. We got to figure out why they have chronic motility issues. Mm-hmm. Check out their vagus, look at the palate, see if they gargle, listen to their bowel sounds, see if you see traumatic brain injury, see if you see rigiditive stiffness, hypokinesia. So motility issue is neurologic. So when you look at gastrointestinal disorders, when you look at like so we know that digestive system is important, impacts all these systems, the microbiome impacts all these systems, but then the other question is how these other systems all impact the gut, because the gut can be dysfunctional with these other systems. You could have someone who has uncontrolled diabetes, HbA1c levels, let's say above 8, and they're totally having their enteric nervous system destroyed, or that's happened in the past. Or they have chronic celiac disease. It took them 10 years to get diagnosed. Now their gut nervous system is injured. And neurons can branch and grow, but only to some degree. So I would really be concerned about enteric nervous system integration at those points, not so much about the supplement. And if that's the case, there's some things that we talk about in the course that we're teaching, the Kharrazian GI course, because we go through all this in over 2 days in a step-by-step approach and all that. But for those types of patients, you have to do vagal exercises. So when you find out that the mechanism of their dysfunction and their chronic constipation is, let's say, neurological, you're not going to be able to get away to treating that with a supplement, right? So you have to activate the vagus. So one of the things that we talk about and use is vagal exercise, like gargling. So when you gargle with water, so if you take like a glass of water like this and then put it in your mouth, I'm not going to do it. I want to gross anyone out. If you like gargle as aggressively as you can for a period of time, those palatine muscles are activated during gargling or activating the vagus. So when you activate the vagus palatine muscles, you activate the entire motor nuclei complex. So that has an impact on the gut as well. So we'll have a person, for example, take one of these glasses like this and then swallow and then gargle for like 1 or 2 minutes as aggressively as they can, and then swallow and then get through the rest of the glass, and do that 3-4 times a day to start to activate their vagus. It's kind of like their smooth muscles in their gut's not working and the nerve plexus of their gut are growing. How do we develop plasticity? How do we get activation there? So gargling is like one of the easiest and most effective exercises. Now, when you look at the when you look at the pathways for the vagus to the gut, it's these are the brachial arch derivatives of the brainstem, then the lateral brainstem. And in these areas, you have vagus nerve and you have cranial nerves 7 and 9. So right, you have the vagus nerve, superior inferior salivatory nucleus and superior salivatory nucleus. And they're involved with saliva and tearing as well. And enzyme release is involved with the nucleus and because they're all part of one branch. So when you activate one, you activate the other. This is the concept in neurology called phylogenetic homologs, because embryologically they're all the same tissue. So if you're actually gargling effectively and aggressively enough, you should start to have tearing. And what we want to have our patients do is to have tearing and then gargle and then hoping that is going to get their smooth muscles to contract. So I would pick gargling over psyllium or lactobacillus. And then I would, in that question, and then I would then go back and go, is there a concern for early Parkinsonian issues? Is there a past traumatic brain injury? And because this sounds like an enteric nervous system issue. And if it's the enteric nervous system, there's two possibilities. One is the brain-gut axis isn't working, right? And the other one is there's inflammation, degeneration of the gut. So chronic intestinal inflammation for a long period of time causes scarring. That could be there, or early Parkinsonian expression.
Great. I do want to just mention the upcoming course, and so AIHM has partnered with the Kharrazian Institute, and we're just really excited about this partnership because one of our goals is to really give the clinicians in our community access to the best training that they can have. And I really feel that this training is such an incredible course, Gastrointestinal Clinical Strategies and Treatment Applications. So this is coming up next week. It starts on Thursday, January 28th and runs to Sunday, January 31st with a possibility of upgrading to have access to the content for up to a year. And I will just say that the amount of content that you provide and resources is just exceptional. So we're really looking forward to this, and I'll share at the end of the talk today how you can sign up and how you can register. But I really am just thrilled to really be partnering with you, Dr. K, because just seeing so many different teachers in this space for so many years, I've never not seen you and just been awed by the amount of information that's just so useful, and the strategies really, just you've been talking about this here. If you jump from here to here, you just, you end up with patients who have bags of supplements that are really not getting helped, and so it's really about learning that process and really learning those strategies. So I'm really looking forward to that.
Thank you. And I would also mention, we have an enormous amount of peer-reviewed references in the course. So it really, the key thing is to see what's published in literature, but also you have to have a background of actually working with real patients to then interpret it and then putting those together. And then for me, like everyone else, I attend seminars all the time. I mean, it's just, we all do that.
Yep.
and then when you actually have been in the seat of taking a seminar, you're always going, oh, what am I going to do with this? So I really wanted to make sure that on the second part of the course, once we go through all the research on the mechanism and all the physiology, we have a very focused section. Here's a step-by-step evaluation from the medical history to intake forms to looking at labs to then figuring out what's your priority. And when it comes to the GI tract, you can always find things wrong. The biggest battle is what's your priority? How do you prioritize what kind of treatment effects are, and then get into a treatment plan, and then whatever review of the literature is that impacts each of these mechanisms or evaluated. So the goal is to take the latest research within an actual clinical model and actually teach a step-by-step approach to evaluate and work through a patient. It's not like, here's this magic protocol for everyone. It's like, stay away from the magic protocol, stay away from the magic supplement, do your diagnostic process. For example, is it motility? Is it autoimmunity? Is it things that are impacting the gut that are metabolic? For example, diabetes being a major disruptor of the gut, and this dysglycemia, hypothyroidism can totally disrupt the gut and cause no thyroid symptoms whatsoever. It impacts so many pathways of the gut. So figuring out what the vector is that's causing the issue is really where the game's at. And
questions from the audience. Will, so we had one question: would this be helpful to psychiatrists? I don't examine patients in the way that a primary care physician does, but would this course be helpful for me?
Well, there is a uh, gut-brain connection. And there's tremendous effects of the gut on its impact on the brain. And there's, they're called canalized, non-canalized pathways that impact the brain. So canalized pathways are the direct inputs and feedback from the vagus to the brain. And these autonomic neurological inputs impact blood flow and vascularization to the brain. And there's also growth factors and peptides and different signaling agents that are released into the bloodstream that then impact the brain. So there's been lots of studies that link microbiome imbalances to depression and mood disorders and anxiety disorders and so forth. So it just depends on what kind of, I guess, psychiatry practice you have. But I will tell you, if you're dealing with mood and cognitive disorders and anxiety, and you're just focusing on the brain, you're going to fail with the large population of them. So, that's one of the things too. Is like people become, one of the problems we have with the human body, it's so complex, and because it's so complex, we have to have special people that are specialized in one area. But then when you specialize in one area, you also have to know how everything else impacts that one area. And at least in a functional medicine integrative approach to make a difference. So the gut is important. And if you haven't had a lot of experience working the gut and you want a thorough step-by-step approach of how to go through it, and I would say yes to the course.
Yeah.
So
yeah, I mean, it's so essential, just when you look at root cause medicine, and the gut really does impact us in every single area. I just think it's to really understand that. This would be a great course to get that kind of foundational knowledge. Another question, Dr. Kharrazian, I'm a DACM student of health sciences at SCU. I was curious to know if you've ever worked alongside an acupuncturist, and if so, what were the outcomes?
Well, when I first started practice, I had a large office, and then not first, midway through my career, I had like a 10,000 square foot office and 150,000 overhead a month, and I had different practitioners in there, and we had a very talented acupuncturist in there. But I didn't, she would get great results doing what she was doing. But the key thing is it's just different models. So we know, for example, let's just talk about acupuncture in general, because acupuncturists, you can practice how many different ways? And you can practice traditional Chinese medicine, you can do functional medicine, you can do various things. But acupuncture itself has phenomenal effects on the brain, and there's a lot of research on how different areas of acupuncture activation impact things like the insular cortex and the amygdala, and the different regions that can increase blood flow and cellular change in the brain. So, for me, I think a lot of the major effects of acupuncture are neurological and neuroendocrine immune, but I don't have enough training or experience with them to do that. But at the end of the day, there's a point where you have to have the proper diagnosis and assessment too, right? So, one of the things that, if you kind of take a look back at the healthcare system, there's some people that go, this is what I do, and then you may or may not respond to it, and they just do their treatment. And there's others that go, I don't know what I'm going to do. Your condition is going to dictate where we go. It's more of a diagnostic approach, right? So the model we teach may not be everyone. Our model is the diagnostic approach. So our treatment's based on those things. Now, you probably can activate the vagus through acupuncture through various mechanisms, knowing or unknowing. So I think it would just be a good adjunct for sure, but you still have to come up with the diagnosis and figure out the mechanism.
Yeah. Another question, beyond the conventional medicine protocol, do you have suggestions for acute, mild, moderate concussions given the gut-brain connection?
Yes.
Also, can you maybe state again any labs that you like to work with, or comprehensive stool tests, or just kind of any thoughts around labs?
Sure. So the first part of the question, as far as mild, moderate, and severe head trauma or concussion, we did create a course at the Kharrazian Institute, which is a 12-hour course called Neuroinflammation, and we go through all of the recent research and the impact of brain injury and what it does to the neurons and glial cells, and then how to deal with those issues. Maybe that's a different topic for a different day, but ultimately there is part of it is a brain gut mechanism, because what we do know is when dendritic cells in the gut get activated, they immediately activate microglial cells in the brain, that they have a bidirectional relationship. So activation of one can activate the other. So, the saying gut on fire is brain on fire does exist. So, when you look at someone who's got a brain injury or concussion, there's two variables involved. One is how hard they hit their head. The other one is their pre-existing state of glia cells before the injury. So if you have someone who's got an inflamed gut, inflamed brain, maybe they have celiac disease, they have leaky gut, leaky blood-brain barrier, the gut's inflamed, and you have another person that doesn't have those things, they get the same brain injury, one's going to have a greater effect from it because of the underlying inflammation. And one's going to be able to recover faster versus another one. So when it comes to traumatic brain injury, you're looking at all the different things that impact the glia. As far as it relates to the gut is one of these things that we focus on. But again, the endocrine system, immune system, they all impact these glial cells. So I don't have just a quick supplement takeaway from that. Second part of the question, as far as labs go, we talk a lot about them in the course, but comprehensive digestive stool analysis, markers for intestinal permeability, are the basic profiles. I tend to like the Genova profile. I know people have different preferences for labs. I like the one Genova offers. I think they do a good job, and they're a lab I've trusted for a long time over the years, and I think they have a great team there. I like the Cyrex panels personally for their immune testing and their leaky gut panels and looking for autoimmune markers. So those are the two most popular common tests we use. But then, you may have to do a breath test to find SIBO. You may have to do H. pylori testing to look for those other mechanisms. You might do PCR for certain infections. So it really depends on what you're looking for as far as labs go.
Can you speak about what causes post-infectious SIBO and how to treat it? It's a big question.
Post-infectious SIBO is going to be injury to the nerve plexus. So that's really what it is. So if you have a significant and severe type of infection, you can get damage to the nerve plexus, but it's 1 degree more than just an infection, because everyone has an infection has it. The underlying mechanism has to be what's called cross-reactivity. So cross-reactivity means you get an infection, you make antibodies, but those antibodies also bind to your tissue, not just the pathogen. That causes severe destruction. That's why not all infections have the same effect. So if you have an infection, you get inflammation, your immune system deals with it, that's fine. Some people get an infection and they have antibodies formed against the pathogen, but those antibodies from the pathogen cross-react with their own tissue. So you can there's lots of cross-reactivity with myelin and neurofilament that can happen right in the gut that takes place. So it's kind of like the model of MS, like hepatitis B can cross-react with myelin, as an example. There's many other ones, but cross-reactivity is one of these most likely mechanisms, and then the enteric nerve plexus gets destroyed, and then they have those issues. So I would suspect you would see some neurological antibodies that are still there after the issue. So you want to measure things like myelin basic protein, myelin-associated glycoprotein, neurofilament antibodies, alpha beta tubulin antibodies. You can do those through the Cyrex as a general lab to see if those are there. And so I would think that the post-infectious SIBO is injury to the nerve plexus, most likely due to cross-reactivity. And by the way, I just want to share with you, we published 2 days ago in Frontiers in Immunology a paper on cross-reactivity with SARS-CoV-2. So we checked spike protein, nuclear proteins, membrane proteins, and envelope proteins, and we checked them against 54 cell tissue antigens, cell tissue proteins, and we found that there's some likeliness of developing autoimmunity after COVID infection for some susceptible subgroups, and it was mostly neurological, mitochondria, and thyroid. So that would be, for example, someone may end up with an infection, and they have cross-reactivity, and then they have those effects. So if you go to Frontiers Immunology, just type in my last name, the paper will pop right up. You can download it for free.
Yeah, I'm going to I'll post it in the chat.
Okay, I can send you a link.
Yeah, that's great. I've got the link right here. Another question just around bile salts, how you're testing those, if you're testing them.
Yeah, that's the problem. You can't really test bile salts. So it's one of those things where you just have a patient that's gallbladder issues. You can certainly send them out for an abdominal ultrasound and see, sludge or biliary stasis or even some gallstones there. And if they have gallbladder sludge or they have, gallstones there, then they don't have efficiency with releasing their bile salts. You can also do you can have a person do an ejection study to see how much ejection they have with the gallbladder. And if those are if those are ejection values are low, then they're probably not getting bile salts to their gut. So you have to kind of use a surrogate marker or look at it indirectly and just assume if the gallbladder isn't working efficiently, it doesn't have enough ejection, or there's sludge or stones in the way, they're not going to be releasing as many bile salts.
Another question around the Nutrio test for SIBO. Is that something you have heard of or are using?
I don't have any experience with it, so I can't comment on the Nutrio test. I just do the standard hydrogen methane test. And we know that has some limitations because not all bacterial species release methane or hydrogen, so some of those get missed. But I think when it comes to SIBO, the most effective thing to do for your diagnosis is to just put them on a FODMAP diet for 10 days and then see if they get better. If they follow a strict FODMAP diet and they have the blowing and distension go away, that's probably your best diagnostic tool, because even aspiration and bacterial culture, which is the gold standard, has many false tests, you know.
Have you heard of there being post-infectious SIBO from COVID, since it does affect the intestinal epithelial and nervous system?
Yeah, well, the study we published shows without doubt that the spike proteins, the nuclear proteins, can cross-react with neurological tissue. So that possibly exists. So here's the thing. What we did in our study was map out epitopes of similarity between the different proteins of the virus and different tissues. And then what we did is monoclonal antibodies to look at cross-reactivity, which is the combination of those two really is the way you check for molecular mimicry. And then we published all those findings. Now, that doesn't mean everyone that gets infection is going to get cross-reactivity, because it's just cross-reactivity plus immune dysregulation, loss of tolerance. So for some people, they get the infection, they'll just get the infection, they resolve, they get immunity, they're fine. Other people have immune tolerance dysfunction. Maybe their thymus autoimmune regulatory genes not working. Maybe they have dysfunctional regulatory T cells or whatever. And then they get the infection and they'll be prone to this cross-reactivity mechanism. And we don't know how to identify those subgroups in a laboratory clinical setting yet. So it is absolutely possible that SARS-CoV-2 infection can lead to neurological cross-reactivity and totally destroy the gut nerve plexus based on those mechanisms. Yep.
Great. Another question coming from our Facebook audience. Once Parkinson's has been well established, is there an option or suggestion you have to help constipation for folks on carbidopa or levodopa already?
Yeah, I think the key thing is to do vagal exercises. Gargling is one we talked about. You can take a tongue blade and then have them do gag reflexes on their tongue. That will really activate the vagus. And they start tearing right afterwards. Like you go, ah. You gotta make sure they don't touch the palate, and just have them go to Amazon, buy a box of tongue blades, and then they can do gag reflexes. Another way to really aggressively activate the gut enteric nervous system is to do a coffee enema, but to hold the coffee. So when you have a coffee enema, it has to be strong enough, because caffeine activates acetylcholine nicotinic receptors in the gut. So it causes the muscles to contract. And if a person does a coffee enema that's strong enough in coffee and they suppress their bowel movements, that activates the brain-gut axis vagal pathway to get some activation there. So you would definitely want to do some aggressive vagal exercises that way. And then a lot of the great research has been shown on burst activity really impacting Parkinsonian progression. So one part of it is try to get the vagus to work and slow down the progression. And very aggressive burst activity like quick movements, kickboxing. Like for me, my preference of choice for people that have Parkinsonian disease is to do kickboxing or dance, something where they're getting the moves and legs bursting very quickly. So those quick burstings get the activation of the direct pathway of dopaminergic pathways that then seems to have a protective effect on slowing down the progression of those pathways and keeps their dopaminergic pathways plastic.
All right. So, got some attendees who love kickboxing, they're saying.
Yeah.
Great. And dance too. So
they don't need the impact, they just need the burst.
Well, we are about to be out of time. I just really want to thank you. This is just such a great webinar today, Dr. K, and hopefully I invite you all. We've posted it on Facebook and also in the chat here to really look at the upcoming course this week with Dr. Kharrazian, the Kharrazian Institute. It again runs from Thursday, January 28th to Sunday, January 31st. And it was really just a phenomenal information and resources beyond what you could imagine in a 4-day course. So I invite you, hopefully Dr. Kharrazian will have you back, and just really thank everyone for coming today. I want to just continue to remind you that we began our community webinar series back when COVID broke out in March, really to just be a support for our larger integrative community. We have Monday meditation at the beginning every week, and we end with a Friday wellness webinar every week. This Monday, Dr. Rachel Abrams will be leading us off in a meditation at 8:30 a.m. Pacific time. And then next week in our Friday wellness webinar, we'll have Monica Eldon, an LMFT, speaking on how to listen to the wisdom of your body, a transformative process for healing and restoring balance. All of our webinars are free for everyone. We live stream them to Facebook, and then we really encourage you all to join our YouTube channel, youtube.com/AIHM Global. All of our webinars are posted after they're free, and you can get them and use them as resources, share them with your community or your patients. And consider joining the AIHM. We are one of the largest integrative health communities globally, and we are growing, and we really just are here to provide support for all of you who are out there as clinicians working to take care of our planet and our people. So Dr. Kharrazian, thanks again for joining us, and we hope to see you all next week at the conference. Bye-bye now.
Bye. Thank you.